Hello, this is Dr. Neyman. I'm the Director of Research at Community Medical Center in Toms River, New Jersey, part of the RWJBH Health Network. This is part of my research rotation lecture series. It's a series of fundamentals on how to interpret research. This first lecture is a broad overview on what I feel is a big interconnected set of problems in biomedical research, both the conducting of it and also, more importantly, especially if you're never going to participate in research, the publication and peer analysis of research. Let's get right into it.
This could be it.
Well, it's a strong maybe.
Well, it could be it.
This could be it.
Jesus Christ! I think we got it. Yeah!
And who are you?
Just a guy.
So I'm just a guy, as this guy in the yellow coat points out. Even though I wear the uniform, I'm not uniquely qualified to critique the state of research. I don't, have any special insight into it. These are just my opinions, but I think this approach will help you develop a framework for dissecting research and not be intimidated by it and just think it's unapproachable by you, even as a physician with a degree. So take this moment to pause the video and think, what do you think are the problems with biomedical research this day? And yes, there will be spoilers ahead, as the YouTube community likes to say, for what I think are problems in biomedical research. All right, have we come back? All right, let's continue. So I anticipate a lot of people would say, oh, the pharmaceutical industry is really, driving a lot of shoddy research. Well, possibly, but from clinicaltrials.gov, they have a total of about almost 400,000 studies, and about a little under a third of them are actually funded by the pharmaceutical industry. So they can't be more than a third of the problem. So there are a lot of other studies, and pharma influence, while is important to dissect. I'm not going to get into that because it's too obvious and people are looking into it. I'm going to look at more of the subtle ways that research can be misleading. So let's start with the publish or perish culture, which basically means everyone in academia must make a certain amount of studies. So yeah, and failure to publish can really have detriments to someone's academic career. There is some literature which focuses on the publish or perish culture, but most of it looks at plagiarism, retractions, and actual hard research misconduct. And I'm not going into that. I'm going into some of the softer, grayer research shenanigans that I don't think technically count for misconduct, but I would say are misleading when trying to embellish research. And even, like I said, even not technically misleading research can also be pressured or rushed. All right, publication bias is the systematic bias of journals to publish stuff that's interesting, like a man biting a dog. That's pretty interesting. So if you do a negative research study and nobody cares about it, it's not going to get published, no matter how much time and effort you spent in doing it. All right. And the reason Thomas Edison was pictured on the front of this lecture is because famously he took about 1,000 tries to formulate the correct composition of a light bulb. And I think 999 failures to one success is a reasonable expectation in scientific inquiry. So what that means is publish or perish plus publication bias plus 999 failures is most published studies have to misrepresent their results. And I hope you're following the red yarn lines that Charlie and I have made to put this together. I hope it isn't too convoluted. All right, so the objective for this lecture is I want you to approach every study that you critically appraise as how that they are negative findings and how are they possibly dressing it up as positive findings. And to that end, I'm going to provide a common sense framework that'll allow you as a reader to pick apart research articles based on frequent weaknesses that I've encountered. And I want you to not just be intimidated by this research, which sometimes uses obtuse language and can really spin your head around until it becomes hard to critically appraise. So what I like to do is I start at the very end. I look at the conclusion section, and it fundamentally will list all the author's biases going in terms of this is what they hoped to prove by their study. So how can you, when you read the rest of the other sections, you think back to how does this prove or possibly undermine the conclusions that they are going to get to. Patient selection, I feel, is the easiest way to stack the deck, even in a randomized controlled study, and it's based on the inclusion and exclusion criteria. So you got the social determinants of health, and it's very common to limit geographical areas because some people can drive into the academic center and some people can't. But how are you stacking the deck by excluding rural patients? If you very frequently, I've got smokers here, but very frequently pregnant patients are excluded from clinical trials. How could that affect an outcome of interest? Smokers as well. So let's take a look at this flow chart. This shows how patients were included and excluded. Does anything jump out at you? And a lot of students point out that, yeah, about a 50% exclusion rate is kind of a red flag in that our patients with meaningful outcomes being systematically excluded in a way that might bias the research. Try to find what the biggest reasons are. What does timed out mean? When I looked at this study, I didn't understand what it meant that patients timed out of the study. And it is like 40% of the excluded patients. So about 40% of the excluded patients don't have a really good explanation for why they're excluded. And also just think, if someone's too busy, is that going to systematically impact the outcomes that you see in the treatment and control groups? Next, you look at the outcome measures. Firstly, are outcome measures subjective or objective? And my hard and fast definition for it is subjective measures are measured by human assessment, which means that it's like if you're feeling dyspneic, how dyspneic you're feeling, you can only tell a clinician, give like a rating, and different people will feel different levels of breathing difficulty, and they will rate their dyspnea differently. So that is subjective, as opposed to objective, which is a respiratory rate or tidal volume, which are objective measures of how well a patient is performing respiratorily. If the outcome measures are subjective, it is very important that interventional based study is blinded, because the mere fact that patients are getting a treatment versus getting control will impact them. They will think, "Ooh, I'm getting the new expensive thing. I'm going to feel my subjective assessment of my symptoms are better." And also you want to ask, are the outcomes disease oriented or patient oriented? And just very briefly to describe what those are, patient oriented outcomes are things that patients care about. They don't go home and say, "Oh, my troponin leaked to zero point 0.5 nanograms per milliliter." They say that I can't walk up a flight of stairs anymore. Those are the kinds of things that they care about. And here's some examples of patient-oriented outcomes. And the reason that these aren't used a lot is because they have a smaller magnitude of effect. It's very frequently a binary outcome, or it's various percentages, scores on subjective scales. So it's can be very coarse, and that the math of how you make p levels in frequentist testing makes it harder to achieve statistical significance. Disease-oriented outcomes are everything that patients don't necessarily care about, but clinicians are all on top of. So you got blood pressure differences, you've got, troponins, you've got tests, you've got all these things. Anything that the patient is not going to measure at home is something that they do not care about. And because their set points are arbitrary and you can slide the numbers and you can pick a different, like, here's my cutoff for this, here's my cutoff for that. You can artificially make smaller differences, absolute differences, statistically significant that way. Here's some from about 20 years ago, which was when I was in medical school, and they were all the rage, and now nobody remembers what they are because they proved not helpful. Zetia is actually still used as a combo product, but it can't be used by itself because its impact on lipids was superior to statins, but there was no impact on mortality. So it's almost as if lipids are a marker for cardiac disease and not necessarily a cause in and of itself. And Natracor was a IV drug used for heart failure that the outcome measure was in pulmonary artery capillary wedge pressure, which is hardly even assessed anymore, let alone does anybody care what it means. And it actually, the use of that drug showed increased 30-day mortality. So Natracor is no longer even available. So I'm not going to stress anybody out. This is a 4th-year rotation. It's not designed to make you question your choice of going into medicine as a field. But all right, we're going to touch base on statistics. We can't ignore them, but there will be no quizzes on statistics here. I'm lying. There will be quizzes on statistics, but not in this video. So, is the paper using measures that you've heard of in other papers, very familiar ones? And here's like the Sinister 7 here, or 6, or 5. So if they pull out a test that you've never heard of, that you're needing to Google and figure out what it is, then I always get worried. Does that represent a post hoc analysis that gave them a good p-value, and they neglected to mention that it was a post hoc and not a priori design? All right. My rule is if you are bringing out an uncommon statistic, you need like 2 to 4 sentences to just describe, this is why I am using this statistic, because it is good for this particular use case. And that usually means that a methodologist or a statistician has helped you formulate this study. And that's usually a good step. All right. I want you to take a moment and look over this method section, the stats section specifically. Pause and read it, and then we're going to go over just, hey, what's that statistic? So t-tests, yes, everyone's heard of that, and Fisher exact test, and what is a partial ETA squared? I've never heard of that. No, I'm not sure what a Cohen's conversion table. So that's not necessarily red flags. That should just make you stop and say, hey, can they explain why they use this test? And ideally, in the best, you know, the best papers, they do explain why they would use those. All right. Now we're moving away from the methods and going to the results. The first step in the results is the demographics table, also called table number 1. It shows you what's how the spread between the different groups, male, female, race, insurance status, significant comorbidities, how they spread out. In a randomized control trial, this would tell you, what was randomization maintained, or was there an inappropriate failure of randomization in which one input of interest, such as smoking on cardiovascular disease, accidentally was cohorted in one group or another, which sometimes can happen with randomization. So they should ideally be even in both groups. And if they're skewed in a factor that may affect outcome, you have to remember that and say, this might undermine the conclusions. And then you go to the results. And the most important relevant data is going to be in the tables and graphs. And what you're looking for here is some kind of wowie result, where it's like, this is the best thing since sliced bread. And that is incredibly, incredibly rare in medicine. Right now, science has it so we're really, in most cases, any improvement is incremental, because a lot of the biggest ticket items have already been purchased by medical care. Very rarely do we stumble into some kind of paradigm shift that delivers huge results. Then you look at the limitations and just they make sure that they're mentioning limitations, but not saying, oh, that's not that big of a deal. I usually skip the background section unless it's something I'm not terribly familiar with, in which case I will use the background section as a refresher. So just wrapping everything up, science is trial and error, and it's very heavy on error. 999 failures to 1 success is a good day for science. And publisher perish and publication bias means that the positive results are almost certainly negative results that are being dressed up as positive results to squeeze it in for publication. All right. I'd welcome, if you're taking the course, I'd welcome any questions emailed directly to me. You can also comment on this video if you're not taking the course. There'll be an end card with the quiz. Also, I'm going to put the quiz link in the show notes. Thank you for watching.